Sir Percival Pott, an English surgeon, described a complication of frontal bone fracture, and this was termed as Pott Puffy Tumor, which refers to edema of part or all of the forehead due to a subperiosteal cellulitis or abscess associated with the frontal bone osteomyelitis. Most common cause of PPT is acute or chronic infection of the frontal or ethmoid sinus. Head trauma, particularly frontal bone fracture, is the second most common cause. Less common causes include cranial surgeries, dental infections, mastoiditis, cocaine abuse, malignancy, insect bite, and acupuncture. And the risk factors are diabetes mellitus, allergic rhinitis, chronic renal failure, aplastic anemia, and other conditions that can cause immunosuppression. This is caused by polymicrobial infection. The most commonly identified organisms include non-enterococcal streptococci, anaerobic oral bacteria, and staphylococci, with streptococci being most likely to cause intracranial complications. Occurs across all age group and most commonly seen in individuals between the age of 6 and 50. This age range coincides with the peak growth and vascularity of the frontal sinus, which increases the potential for hematogenous spread of infection. In the pathophysiology, communication between the frontal sinus and the dural venous plexus through valveless diploic veins of Gallen can allow septic emboli to spread, leading to intracranial involvement with or without frontal bone erosion. And also this frontal bone osteomyelitis can arise from direct extension of an infection following an open trauma to forehead. The most common symptoms include forehead swelling, headache, purulent or non-purulent rhinorrhea, and fever, typically present with a fluctuant, tender, doughy edema of the frontal scalp, which may be localized or generalized. There can also be glabellar and subperiosteal swelling, nausea, vomiting, and cutaneous fistula. Increased intracranial pressure should be suspected if the patient develops nausea, vomiting, photophobia, cranial deficit, hemiparesis, seizures, or altered mental status. Both CT and MRI are useful in evaluation. CT is for assessing airborne interfaces and any frontal bone or skull base involvement, while MRI provides more detailed imaging of the soft tissue anomaly. Laboratory tests include a complete blood count, comprehensive metabolic panel, erythrocyte sedimentation rate, and C-reactive protein, along with a test for suspected immunocompromising conditions. This CACT of the head, and the upper one, the red arrow, is showing a frontal osteomyelitis along with erosion of the anterior table of the frontal bone, and the below diagram showing two large subgaleal abscess with the thick arrow, osteomyelitis of the frontal bone which is circled, and intracranial extension into an epidural empyema shown by the thin arrow. Treatment mainly include a combination of systemic antibiotics with a surgical abscess drainage, debridement of the devitalized tissue, and restoration of the frontal sinus outflow tract. And in the empiric antibiotic therapy is recommended. The recommended options include penicillins, which is mainly ampicillin sulbactam and piperacillin tazobactam, vancomycin, fluoroquinolones, third or fourth generation cephalosporin, along with metronidazole. And once the culture and sensitivity results are available, antibiotic coverage can be refined to more targeted long-term therapy, and mainly it is lasting for 4 to 8 weeks. The primary goal of surgery is to drain the extracranial and intracranial abscess, and this can be through an endoscopic approach or frontal refination. And the incisions are mainly Lynch-Howard incision, osteoplastic frontal flap through a bicoronal scalp incision, or a bifrontal craniotomy if associated intracranial complication, and extensive osteomyelitis of the anterior table needs a Riedel's procedure.